we'll just be presenting our experience. Dr. Soham will do that, a spectrum of cases, and then we'll discuss shortly that how can these the Western guidelines be replicated in the Indian setup, and what are the current Indian challenges. Soham, go ahead.
Good morning, respected teachers and my dear colleagues. I am presenting a CGR on primary percutaneous coronary intervention in ST-LVS and myocardial infarction. Why the discussion on ST-LVS and myocardial infarction is important? What are the available reperfusion strategies, data from our department, and final discussion. India has seen a rising prevalence of coronary heart disease over the last 6 decades, both in urban and rural populations. It's a 7 to 10-fold increase in urban populations and 3 to 4-fold in rural areas. Various differences have been reported in Indians as opposed to their Western counterparts. Coronary heart disease develops a decade earlier, often more severe and diffuse. Acute myocardial infarction is frequent. Approximately 40 to 60% of all acute coronary syndrome cases, which is much more higher than what is reported in the West, where it is about 1/3 of all acute coronary syndrome. In fact, 3 million of ST-LVS and myocardial infarction occurs every year in India. Not only do Indians have atherogenic lipid profile, but the reported mortality is also higher. In Indians, the cardiovascular death rate per 1 lakh population is 381.5 and is much higher than the global average of 235. Death as well as disability from coronary heart disease have increased 1.5 to 2-fold in India in the last 30 years, as demonstrated by the data from the Registrar General of India over the last 2 decades. Management of acute ST-LVS and myocardial infarction primarily focus on early reperfusion. In this context, the first 12 hours following an myocardial infarction is the time of maximum opportunity for initiating the appropriate reperfusion therapy. It is established that reperfusion, either in the form of pharmacological or mechanical, must be instituted in all patients, especially when symptoms are ongoing and in all cases of cardiogenic shock or heart failure, irrespective of time delay from the onset of symptoms. Currently, all guidelines endorse the primary percutaneous coronary intervention as compared to fibrinolysis, and it is the acceptable gold standard of treatment. What is primary PCI? Emergent percutaneous catheter intervention of the infarct-related artery in the setting of ST-LVS and myocardial infarction without previous fibrinolytic treatment, and rescue PCI when it is done in the setting of failed fibrinolysis. As far as fibrinolytic agents are concerned, many agents are available. However, patency rates range only from 30 to 65% as compared to primary PCI, which has an immediate patency rate of more than 90%, which translates into better ventricular function and lower rates of long-term adverse outcomes, including mortality. Whereas fibrinolytic agents, as already mentioned, have modest patency rates and are also associated with the risk of re-occlusion after initial restoration of flow. Stroke and intracranial bleeding are another important adverse outcomes of fibrinolysis. The practical issue is that primary PCI 24/7 is available in less than 5 to 10% of centers, and even though fibrinolysis is widely available, only less than 50% of those actually receive it. Coming to our SCPGI data, a total of 163 patients revived primary PCI, which year-wise distribution as depicted, and expectedly a substantial fall during the COVID times. Primary PCI per se form 5% of the all angioplasty procedures done over the years. Demographic analysis of this data revealed the mean age of the patients population receiving primary PCI was 59 years, and 1 in 5 patients were aged less than 50 years. Approximately 85% were males. Nearly 2/3 had diabetes or hypertension, while impaired lipid profile or history of smoking was noted in nearly half of them. Importantly, nearly 60% had multiple risk factors, highlighting the adverse cardiometabolic profile of these patients. Mean presentation time to the hospital was 7.88 hours, and only 8% of those patients had received fibrinolysis. About 2/3 had anterior myocardial infarction, and then 1/3 had inferior myocardial infarction. The corresponding culprit or infarct-related artery was left anterdescending in approximately 60%, and either the right coronary or circumflex artery in 30% of cases. In the background of STLS and myocardial infarction, the baseline LV ejection fraction was impaired. That is mean LV ejection fraction of 37%. Usually the strategy is to perform the culprit vessel stenting in the primary procedure, and often ancillary treatment in the form of glycoprotein 2B and 3A is given. In our series, an hospital mortality of 6.9% and a 30-day mortality of 10.8% was noted. Those more likely to have adverse outcomes were those who had larger infarct, as suggested by adverse hemodynamics at presentation like cardiogenic swab, impaired renal parameters, and LV ejection fraction of less than 25%. I will now proceed to show a few cases representing the spectrum of primary percutaneous coronary intervention in the setting of anterior myocardial infarction, inferior myocardial infarction, complicated myocardial infarction that patients on ventilator or complete heart block, and rarely left main occlusion and post-CABG graft occlusion. The first case is a 51-year-old male who had an anterior wall myocardial infarction on ECG, had not received fibrinolysis, presented to us at 5 hours, and on admission the echocardiographic LVEF of 40%. Immediate angiography by right radial loop revealed a mid 100% left anterdescending artery occlusion and a normal left circumflex and right coronary artery. The blocked vessel was wired with the angioplasty wire, followed by plain balloon dilatation and the implantation of 3/38 mm stent in the left anterdescending artery.
Aims directly to supply virus.
This is the final result showing the flow in the left anterdescending artery. And the resolution of the
Dr. Manas, your mic, we can hear all what you're saying. Please mute it. Okay, thank you. Go ahead.
The second case is a 75-year-old male. ECG revealed an inferior plus posterior wall myocardial infarction. He presented to us at 2 hours, had not received any fibrinolysis. The LV ejection fraction on echocardiography was 45%. The patient was shifted to cath lab at 10 p.m. in the night after getting a TrueNet negative report. Angiography reveals a mid 100% circumflex occlusion, meaning that this was a dominant circumflex. Thereby, it was a large vessel. The LAD had diffuse proximal disease, while the RC was a small artery. The lesion was crossed with a wire, and looking at a thrombus burden, a clot aspiration was done with an export catheter. Multiple clots were aspirated, as shown in this picture. This was followed by stent implantation and a complete restoration of flow, and the resolution of the ECG changes post-procedure. Patient was discharged after 48 hours. The third case is a 48-year male who had severe viral acute respiratory distress syndrome, who was COVID negative on mechanical ventilation. The patient had a cardiac arrest and was subsequently revived in the ICU. An ECG was done suggestive of anterior myocardial infarction with an LV ejection fraction of 30%. The patient was shifted to cath lab on a ventilator for primary PPCI. Angiogram revealed a severe long segment disease in the left anterior descending artery, while the circumflex and the right coronary artery revealed a mild disease in the left circumflex and RCA. Following wiring of the left anterior descending artery, Due to the long segment of disease, 2 stents were implanted in the overlapping manner. This was the final result showing the complete restoration flow in the culprit artery and the resolution of the ECG changes post-procedure. The ECG was settled and gradually the patient was weaned off the ventilator and discharged subsequently. The fourth case is a 60-year-old male who had an inferior plus right ventricular myocardial infarction with complete heart block. He had not received any fibrinolysis and presented to us at 6 hours. Due to the complete heart block and bradycardia, he was hypotensive and had metabolic acidosis along with the acute kidney injury. That is, serum creatinine on admission was 3.5. A TPI was inserted and the patient was shifted to cath lab on inotropic support. Left coronary injection was unremarkable, while the right coronary was 100% occluded in its proximal part. As described previously, the lesion was wired, balloon dilatation was performed, followed by stent implantation. Flow in the RCA was restored and post-procedure, the ECG revealed sinus rhythm. Subsequently, the temporary pacemaker was removed, renal tension were settled, and the patient was discharged after 4 days. Case number 5 is a 25-year-old female who had an aortoarteritis. The hallmark of coronary involvement in aortoarteritis is ostial or proximal stenosis. This female presented with an acute coronary syndrome and was shifted from immunology ward to cath lab when she had chest pain within 1 hour. ECG showed global ST depression with ST lesion in an AVR pattern suggesting severe left main disease. That was confirmed on immediate angiogram that showed near total occlusion of left main. Right coronary artery was normal. In the setting of such cases, ideally an urgent coronary artery bypass grafting is usually not possible, and hence an urgent angioplasty of left main was performed with a good final result post-stenting. These are the final results showing the complete restoration of flow in the left main. Post-procedure, the ECG was settled and the patient was subsequently discharged. Case number 6, 69-year-old male who had a previous coronary angioplasty to RCA in 1997 and then underwent a coronary artery bypass grafting in 2009. He presented to us at 6 hours and ECG showing the changes of infraval myocardial infarction. The baseline LV ejection fraction was 38%. Angiography confirmed the pre-existing disease in the native coronary vessels and a patent left internal memory graft to the native left ventricle descending vessel. The saphenous venous graft to the obtuse marginal vessel was occluded by thrombus. A clot aspiration into the graft was performed with an export catheter. Balloon dilatation was done, followed by a stent implantation in the vein graft with complete restoration of flow, and post-procedure ECG showing settling of the changes in the inferior lip, and the patient was discharged after 48 hours. On occasion, it is less than 1%, one may encounter an anatomy that is not amenable to coronary angioplasty due to diffuse multivessel disease. And in such cases, following an angiogram, the patient is stabilized with aggressive anti-ischemic measures and subsequently referred for semi-urgent or elective coronary artery bypass grafting in the same admission. The last case demonstrates this. A 45-year-old male with a cardiovascular spectrum of diabetes and hypertension and a chronic smoker is sustained an interval MI and arrived at the hospital within 12 hours. On admission, the echocardiography LV ejection fraction was 40%. He had not received any fibrinolysis. Angiogram revealed a diffuse disease in all the vessels. In this view, considering this, angioplasty was deferred and patient was stabilized in the ward and subsequently referred for CABG. The discussion part will be covered by our head of the department, Dr. Kapoor sir.
Thank you, Soham. So in the next about 10-12 minutes, I'll just describe what are the Indian challenges in terms of implementing STEMI care. If you look at the Western guidelines, what they tell us and how are we challenged in our setup. What is the national data of STEMI care in India and how does our data compare with that? Briefly familiarize you with the concept of an amalgamation of the two techniques, that is a pharmaco-invasive therapy. What has the COVID pandemic taught us about STEMI? So I'll just briefly cover these few things. What the Western guidelines tell us that a ECG should be done within 10 minutes of any chest pain which looks like an ischemic pain. If you are able to offer an angioplasty to these patients within the next 2 hours, do so. However, if angioplasty is practically not possible in 2 hours, we should not waste our time in sort of referring the patient for angioplasty, but within this golden hour or golden period, one should offer thrombolysis to these patients. And that is a problem with our systems, that's often thrombolysis is also not done. If the patient reaches a so-called angioplasty enabled center, then the angioplasty should be preferably done within 60 to 90 minutes. So this is what the West or the guidelines endorse. The Indian challenges are in 4 areas. The presentation times to the hospitals are very long and these get magnified when you look at the rural context. Lack of an efficient or a robust ambulance services, which again magnifies the presentation delays. Cost burden. Most patients often have to pay out of their own pocket. The lack of a robust penetration of insurance services into the sectors of population. And lastly, and most importantly, not many hospitals offer a primary angioplasty service for STEMI patients round the clock. So reperfusion remains very suboptimal. If you look at the older data, 2 decades ago, the presentation times were 8 to 10 hours. Recent Indian registry data in the last decade, we have 4 major registry data, which are, some are pan-India, some are regional registries, 3 are urban and 1 is a rural registry. The important carry-home message is that most of the patients, the age was around 60 years and about 1/3 of the patients were less than 50, which is a pretty sobering fact. In our data also about 20% of the patients were less than 50. Long presentation times from 6 to 13 hours. In our series, the presentation hours were also around 8 hours. If you look at the fibrinolysis rates across India, it's about 40 to 50%. Less than 8 to 10% get a primary angioplasty. In our series, rescue angioplasty or post fibrinolysis was in about 10%. If you look at the mortality data, the Indian data in terms of in-hospital and 30-day data is around 8 to 10%. Our data was also around 8 to 10%, the in-hospital in 30-day. And we look at the international data, the GRACE and the EuroHeart, these are standard and well-known international registries. The in-hospital and the 30-day mortality was around 4 to 6%. So less than what the Indian data shows. But again, this highlights the fact that even in the West, about 6% have an adverse outcome by 30 days. Mode of arrival to hospital, a very, very important thing, because it's published and accepted thing that when people come by an ambulance, if they have an ongoing ST elevation MI, they do better. But the pan-India registry, the CREATE registry, found that only 5% of the guys actually come by ambulance. This is our own published data across the state of UP, the presentations and delays in the management of acute MI. Medical attention was sought within 6 hours in only 50%. Only 5% attended the hospital within the first hour and less than 3% arrived by ambulance. So this is another important thing we have to work on if we want to improve our STEMI care. The third important thing is payment. Again, this is a pan-India CREATE registry. Even in the better socioeconomic status, about 70% of the patient paid for the procedure by themselves, whether it is thrombolysis or angioplasty. The poorer sector or the lower socioeconomic status, 50% of the patient paid, about 1% only received free treatment. So this figure has now improved with the implementation of the other government-sponsored schemes. But again, it highlights the fact that insurance needs to penetrate better into our patient population. Lastly, and more importantly, reperfusion strategies remain underutilized because there is a lack of 24/7 primary angioplasty services across India. This is the pan-India registry. You see only 2/3 of the people received thrombolysis less than 1 in 10 received an angioplasty, and this figure is even more dismal in the regional registries. And this is the National Intervention Council, the Indian data. About 2018, nearly 30 lakh people had a ST elevation MI. Only 40% received thrombolysis. Less than 2% received a primary angioplasty across India. Again, the important carry-on message is that out of all MIs, 60% probably don't get any reperfusion strategies at all. So briefly, I'll touch upon pharmacoinvasive therapy. What is it? So before I conclude, the consensus now is that the patient comes to a non-angioplasty enabled center, like a regional or a peripheral center, where angioplasty cannot be done in a timely way. Then what should be done is fibrinolysis. One should not waste, as I said, time in referring the patient to an angioplasty center, because then you're losing that critical golden hour, or the concept of time is muscle. You're losing those 2 to 3 hours. So the patient should be thrombolized at that particular place within 30 minutes. Then transfer to a higher center for angioplasty within the next 3 to 24 hours. So that is the concept of an amalgamation of the two techniques, pharmacoinvasive therapy, so that you can offer early and timely thrombolysis, followed either by a rescue angioplasty, which we did in our 10% of the cases, the rescue angioplasty if the thrombolysis fails, or a non-urgent angiography to determine the need for any subsequent angioplasty within the next 24 hours. So this is the hub and spoke model which is being talked about in India. You have a central hub A hospital which offers a 24-hour primary angioplasty ability. So at present, SGPGI is one center in the state of UP which offers 24/7 primary angioplasty services for ST elevation MI. I'm not talking about elective angioplasties. This is primary plasty for emergent reperfusion for ST elevation MI. The hub B hospital is which offers plasty only during regular hours. Out of office hours, the patient undergoes thrombolysis followed by an angiography on the next day. This is surrounded by spoke hospitals which are within 30 minutes of the hub hospital. Their only duty is to do an ECG, diagnose an MI, and refer it to the hub hospital, because they are within 30 minutes of the hub hospital, so they can do that. Hospitals which are farther off, spoke D hospitals, more than 30 minutes away from the hub hospital. If the patient comes there, they'll thrombolize the patient. So, not lose time by transferring the patient to the hub hospital. So these hospitals will thrombolize, stabilize the patient, and then refer to the hub hospital within the next 3 to 24 hours. So this is the concept which has to be strengthened in India if we want to improve our ST elevation MI outcomes. And it has been shown that if you implement this and link smaller peripheral regional hospitals to a centrally located, robust angioplasty enabled hospital, say like SGPGI, you will not only improve the timelines of reperfusion in terms of minimizing delays, hospital arrivals, but you will improve mortality. So this is one thing which needs to be done. Briefly, last slide, last 2 slides. What has the COVID pandemic taught us? ST elevation MI may represent the first clinical manifestation of COVID. People might present with ST elevation MI or have an MI while in hospital. So these are ST elevation MI ECGs which we are all familiar with in our COVID ICUs, either anterior, inferior, global ST depression. More data is needed to understand why an acute MI actually occurs. Intuitively, we as cardiologists used to think that it's like a classical type 1 MI, obstructive MI. Because of destabilization of the plaque rupture, increased platelet aggregation. But people started doing angiographies of these COVID patients. Surprisingly, it was found that about 2/3 had non-obstructive coronary artery disease. So there was no disease in the epicardial vessels. So now the consensus is, or the understanding is veering towards that it perhaps could be a type 2 MI, a supply-demand imbalance MI, a non-obstructive MI, wherein the STT changes occur because of the underlying myocarditis, inflammatory cytokine storm, sepsis, endothelial dysfunction. So it's perhaps a supply-demand imbalance MI. And in context of this, like all international societies, the Cardiological Society of India also offered its own, perspective on it, that often for these patients of COVID, the delays will be magnified even further. They may be in the COVID ICUs, they may not reach a cardiology setup. Importantly, troponin levels will often rise in these patients. So it should not be used as a standalone test. It should not be used as a test to activate downstream, cath lab activations or to thrombolize these patients. One has to see the clinical background and not treat the troponin, but treat the patient. So primary angioplasty is still preferred if it can be done with necessary precautions and preparedness. It should not be done in these patients if a PPE kit or adequate logistics are not available. It should be done in a dedicated cath lab with minimum of personnel to minimize the risk to the healthcare workers. Most labs are not negative pressurized. So this is an important thing for cardiologists to understand, that if you do such a procedure, an aggressive terminal clean has to be done in the cath lab before you put in the next patient. So all these logistics means that more often than not, you will probably thrombolize these patients because angioplasty may not be feasible. And we did this in a couple of patients during the COVID times as well. And in a few patients, as we showed, if the patient was in our holding area, came with an ST elevation MI, often we could get away with an angioplasty after doing a TrueNAT. If it was negative, of course, the patient goes to the cath lab. But if the TrueNAT or the COVID test was positive, most of these patients received thrombolysis so that at least they're not denied the chance of pharmacological reperfusion. So I'll finish off with saying that incidence of ST elevation MI appears to be increasing in India as we showed. It occurs earlier. Timely restoration of the artery, whether by thrombolysis or by angioplasty, is preferable. Data shows that angioplasty should be done, but the limitations I mentioned. So we need a robust system of care nationally and in the state as well in order to deliver timely reperfusion to these patients. And what are those steps? First of all, public education so that symptoms are recognized early. People should not underplay their symptoms. If they're having some issue, they should consult a competent doctor or a cardiologist. Activate efficient ambulance services so that the people are able to reach in time. And very importantly, we should have predetermined hospital protocols for the ambulances so that the patient either reaches a peripheral fibrinolysis enabled hospital or a central angioplasty enabled hub hospital. Time should not be wasted in approaching multiple tiers of healthcare so the patient goes from door to door or hospital to hospital. Develop more hub hospitals, as Soham rightly mentioned. Only 10% of hospitals across India and even lesser in the government sector are identified hub hospitals. And lastly, fast track approval for not only angioplasty as well as fibrinolysis to allow for emergency therapeutic procedures to be done so that the patients don't waste their time in sort of organizing finances as well, so that out-of-pocket expenses can be minimized. So if we look at all these 4 or 5 steps, our STEMI care in the future is likely to improve. Thanks for this.